First of all, I want to thank SAPEX for inviting us to present at the conference today. It's a real honor to be here. My name is Dominique Zwinkels. I'm the executive manager of the People That Deliver initiative, and you'll learn a little bit more about us in a moment. So SAPEX is a new board organization for the People That Deliver initiative. And I'm just very excited to be able to present to you today a case study on how to build capacity in the supply chain workforce, or in the health supply chain workforce, in a very challenging environment, which is Sudan. But today I also want to speak to you about the need to invest in the health supply chain workforce, as that's really a proven strategy to improve the overall efficiency of health systems. We have entitled this presentation, Reform of the National Health Supply Chain in Sudan, dedicated to those that work hard to get essential quality medicines to patients. And this is a dedication in the transformation plan of Sudan, specifically to the supply chain workforce in Sudan by Dr. Gamal. So this is a good segue to introducing Dr. Gamal Mohammed Ali. He's the Director General of the National Medical Supplies Fund in Sudan. So,
welcome.
Okay, all right. So just quickly an overview of our presentation today. I'll speak to you briefly about what the People That Deliver is and how does it work. And then Dr. Gamal will speak to you about the National Medical Supplies Fund of Sudan and what it is and how does it work. And then the health supply chain workforce, why does it matter? We'll get into that. And then explain a systematic approach to building that supply chain management workforce in health supply chains. And then we'll end up with the case study. So how to make country-based change happen and show the National Medical Supply Fund's reform process. So I just wanted to raise a few questions before we start. So these are really questions to think of as you listen to our presentation. And these are the challenges and issues that we face every day in the work that we do. So think about this as you listen to the presentation. Think of this as you're listening to the case study. But in many of the countries we work in, the supply chain staff, the health supply chain staff, do not have job descriptions. What are potential problems arising from this? So think of supervision and performance management when you don't have job descriptions. In most countries in Africa, there's a problem of retention of professional staff. What can be done to stop qualified employees leaving the service? Something that we deal with all the time. What are potential consequences when government partners work in isolation? So there's poor collaboration between them. And then finally, in some countries, foreign donors, agencies, partners, stakeholders, they sponsor the salaries of key supply chain managers and logisticians. Is this really the preferred option? So quickly, so what is the People That Deliver? It was created in 2011. At that time, 79 institutions came together at the WHO to sort of pledge their support and action to the mandate of the People That Deliver. And that's really to build the capacity of supply chain, of the health supply chain workforce. But at the same time also to promote and advocate for the professionalization of the supply chain role within the greater health system. It's really based on the premise that without trained professionals in a health supply chain, you're really not getting the drugs and the health supplies to the patients that need them. And it's really a global partnership, a global advocacy coalition of all these different organizations that are working towards a systematic approach in health supply chains with an HR management and development capacity lens. So our vision is a world where the health supply chain workforces are empowered and equipped to optimize health outcomes by improving access to health commodities. We have over 250 organizations that are a part of our initiative. And today we have 23 board organizations that are part of our board of directors. One of them is SAPEX, so we're very happy to have them on board. Our secretariat is hosted by UNICEF Supply Division, which is based in Copenhagen, Denmark. And so now I'm just going to pass it on to Dr. Gamal.
Yeah, I will give a brief about the National Medical Supplies Fund, which is autonomous public organizations, a non-profitable and self-financing organization with 400 employees and a turnover of $225 million US. This is the amount of medicines that we distribute annually. Our main function, like many other central medical stores in Africa, our function is to do procurement for the government, all medical and pharmaceutical products for health system in Sudan, and we also do the quality assurance in management and quality of products. And we do the storage and distribution of health commodities. Actually, we have like 5,000 different health commodities, including medical device, pharmaceuticals, and consumables. Our main customers is public health facilities because we're responsible for the supplies to the public health facilities from the central down to the bottom of the supply chain to the health centers, hospitals in rural and urban areas. We do also distribution of medicines to non-governmental organizations and to limited extent to the private hospital and pharmacies. And this is a model of or part of the reforms that we have done in the supply chain, and we call it our new model, where we just at this point here, when we split the flow of medicine from the cash flow and revenues, because this is we have states in different branches in different states, and we, upon the request of the health facility, we send them the medicines through our branches, and then when users come to fill their prescriptions, they pay for it. So this is the advantage of this model. I'll give the mic to Dominique again, and I'll come back to this model.
Okay. So now I just come back on the podium. I just wanted to speak to you a little bit about why does it all matter? Why? Because all these health programs, they need supplies. We need medicines, we need vaccines, we need contraceptives, equipment, consumables, preventive supplies. They need to reach the clients, the service delivery points through very long and complex supply chains. And of course, that means weaknesses can happen. And with these weaknesses, shortages in supplies can happen. And what does that mean? With shortages in supplies, those are basically the limiters of health outcomes. So we're really trying to work towards improving the health outcomes with this. Health supply chains are people chains. So like all chains, supply chains are no stronger than the weakest link. So even though there's millions of dollars worth of commodities flowing through these health supply chains are not seen as a strategic function within health systems. And so what we also find is that the people are not being trained. They don't have the right managerial and technical competencies to do and make decisions, make actions within supply chains. And so we find that in health supply chains, we need people at the central level, at the district level, and at the health facility level. These are pharmacists, of course, but we also need logisticians, supply chain managers. We need warehouse personnel. We need distribution personnel, administrators. But at the same time, there's also doctors and nurses that are doing some logistical tasks. So I just want to speak to you about some of the challenges that we're facing. So look at some of the challenges, and then we'll go into our case study. This is really the issue. More health workers are needed. There's a global needs-based shortage of health workers, and it's projected to be more than 18 million people by 2030. These are statistics from the WHO. And what you find here, let me just circle these. You'll find here in Africa, the change is 45% between 2013 and 2030, an increase of 45%. These other cadres is 2.2. These are logisticians and supply chain managers are included in that. And that's a piece of work that People That Deliver was able to do, really advocate for the need for inclusion of logisticians, supply chain managers into the healthcare workers cadre in this specific report. What we also see is there's a challenge in the growing demand in commodities and performance throughout the supply chain, throughout health supply chains. So an increase in commodities moving through the supply chain is typically not accompanied by an increase in human resources. And some of these factors that are limiting are, so there's fragmentation of the responsibility for managing the overall performance of the supply chain. There's lack of planning and financing for the workforce. There's lack of development and credentialing of supply chain managers. This is why we're all here today. Lack of accurate job descriptions, lack of professional development and professional associations. You may have this SAPEX here in South Africa, but a lot of countries in Africa do not have professional associations focused on this. Overall, poor performance within immunization supply chains. You see that they're not meeting the WHO minimum performance standards for all the different supply chain functions. Pre-shipment vaccine arrival, temperature monitoring, even information systems. There's also an increased expense and complexity. Larger storage volumes is required. The vaccines, for instance, are costlier and more sophisticated. We're now in our new generation of vaccines. You need people that are better qualified and trained to handle those types of vaccines. There's an increased number of doses that are needed, so you need to be able to order, track, and administer these. So a change in the approach is needed. And our desired paradigm in HR for supply chain management is a long-term focus. This requires a reform of perceptions, policies, practices, and converting existing expenditures into investments, building capacity over time, and making it sustainable and, more important, country-driven. This is really our focus now. So unfortunately, we were going to show you a video. This is just to show you where HR is relevant in the supply chain, and then we had another video of what keeps people engaged in the work. But unfortunately, we can't show this, but I would hope that after our presentation, you would take time to look these up on YouTube. But the Getting Products to People is a wonderful video produced by one of our board member organizations, John Snow International. So as you'll see, human resources really falls all across the logistics cycle. It really looks at the 5 different domains of the supply chain. We need qualified and trained professionals in selection, quantification, and procurement, inventory management, distribution, and of course the rational use of medicines, and of course most important also management and support. So this is the way we have approached our specific people that deliver methodology. And we have built these 5 building blocks of HR for supply chain management. And we support organizations and governments to improve their supply chain performance by looking at building country-level interventions that underpin these 5 building blocks that have been developed through meta-analysis. So these are really 5 key themes that have come out of evidence-based work. Number 1 is we need to be engaged with stakeholders. So we need to have the technical leadership and the advocacy for supply chain management. Then we need to optimize policies and plans that support workforce capacity. We need workforce development initiatives. We need better training. You need pre-service training, for instance. You need to be able to recruit people. Then block 4 is the increase in performance and retention initiatives. So how do we better retain our staff? Do we have performance management plans in place? Are we doing better supervision? And of course, number 5, that's really our long-term goal, so professionalization of the supply chain management role. And this is, again, something that we're here for today. So we have built a 4-stepped approach as to how we can help both organizations and governments create a better capacity plan, a strategy, and implement that. And so number 1 is we really do an assessment of the current needs for HR management and capacity development. Then we move out to mapping the skills, knowledge, and abilities, the competencies that are necessary, both the technical, the managerial competencies that are necessary. Then we include all of that into a capacity development plan, into a strategy, and then create an implementation plan. And so the case study that we're presenting today with Dr. Gamal is really something that went through this four-step process. So we have, over time, built a country partnership program where we're really helping, again, the organizations and countries to build, to plan, to implement reform in human resource capacity. And we do that by these types of services that are included here: initial scoping, developing strategies, doing assessments, doing competency mapping, and developing both training plans as well as capacity development plans. And so now we move on to Sudan. I'm very proud that Dr. Mal is here today. The National Medical Supplies Fund joined the People That Deliver board back in 2013. At that time, he really had the vision to see that he needed to really improve the skills of his supply chain workforce in order to even implement the transformation plan. If he did not have the qualified people on staff, they would have never been able to make these changes that they've made over time. So I'm just excited that we were able to work with them. And then also through his vision and leadership, they've built an incredible state-of-the-art training center. It's built on top of a brand new central warehouse in the premises in Khartoum. And you'll have incredible what you see there. And so in order to support this training center that was set up, Gamal came to me and said, can we work in collaboration, and can you help us develop a human resource capacity development plan? So with the help of a number of consultants with very specific experience, expertise in both supply chain management and human resource management, we helped develop a 5-year strategy, costed implementation plan. From there, we did a competency modeling, developed a competency framework, and from that, we have all new job descriptions for all the staff, and of course that will help inform their career paths as well as the curriculum for both the training that is being done, the training that will be needed, and hopefully the need for academic programs that will be built in country. And there was a number of further recommendations laid out. So now I'm going to pass it on to Dr. Gamal.
Okay. I will give a brief about when I have been appointed as General Director for the National Medical Supplies Fund in September 2010. And one of the big challenges that we faced is the separation of our country in two. And then due to separation, the oil is the main source of hard currency in Sudan during one country time. But after separation, the oil gone with the south. And one of the very big challenge that we faced is the scarcity of hard currency. Because we rely on importation, 80% of our health commodities are imported from outside. So this is one of the very big challenges we faced when I came to these organizations. And as a consequence of scarce hard currency, then the inflation. In 2010, the 2 Sudanese pounds equal $1. But now $1 equals 30 Sudanese pounds, so 15 times inflation, and you can imagine the difficulties. And we are self-financing organization, we are not profitable organization, but we have to work very hard to meet this inflation without, make people suffering from expenses, drugs, or something like that. And then also in our reform, one of the challenges, because we decided on reform and we committed ourselves to work to the rules of law. Before the reform, our organization just buy the medicines which have no marketing authorization in our country. And this has a very bad impact on the quality of medicine. So we decided to stick to the rule and buy medicines with marketing authorization. And as a result of that, medicine registration, so we found like 150 medicines on our list, and very essential medicines for the health system, which has no marketing authorization in Sudan because the importers or the private companies do not interested in this kind of medicines because they are not of commercial value, like vaccines, or their storage and distribution system is very expensive, like vaccines and narcotics and anesthetics drugs. One of the challenges also we faced is the stringent economic sanctions. Actually, Sudan was under sanctions for more than 28 years. the sanction has been lifted in October, but still we are still suffering from that because there is no bank transaction, especially from 2013. And in commitment to sanction, even the shipping airlines, some international shipping airlines and drug companies, big drug companies, committed to the sanction and stopped sending medicines or shipping goods to Sudan. So this is one of the challenges that we faced. And one internal issue is the Civil Service Act. Although our organization is autonomous organizations, but you can't, according to this Civil Act, all member of staffs, they have been hired through a federal system, which a commission for selection and recruitment of staff to the civil service. So me as a manager, I can't, for example, participate in the selection or recruit people that I want. So it is a very big challenge to do your vision and implement your vision through employees who you have no role in their selection or even their firemen. So you have to work with them. And later I'll explain to you how we managed to create a very good team through human resources development and the help of PTD. Also, our organization is so old organization. It has been first established in the mid-1930s during the colonial time in Sudan. And then since that time, the organization do the same functions. So it is very bureaucratic, public organizations. And the internal culture is very difficult. We face with this kind of staff, how you change their mentality from just doing their job according to the book to those kind of staff who are responsive to their customers and be quality-oriented, customer-oriented, and even changes their mentality to, because we are like business-oriented organizations, because we sell medicines and distribute them and that kind of thing. Also, as I mentioned earlier, we have branches in different states. Sudan is a federal system with 18 states. We have branches in 16 states. And our branch in the states is under direct supervision of the Minister of Health at the state level. But because this is a political position, there is a very high turnover. They just stay in their position for 1 to 2 years. Sudan is a very complicated political system. You can't imagine we have more than 150 political parties. And this cake of authorities, they have to distribute it between them to keep peace in that. So also we have the lack of well-trained pharmacists at the state level. Also we have a very big number of pharmacists in Sudan, but most of them want to or work in the private sector rather than the public sector. Also we have security issues in certain states, especially in far west of Darfur and south of Sudan. And we have difficult roads because the infrastructure is still to be developed. We have difficult roads. We have transportation also. We have difficulties in transport and qualified companies to do especially for the health commodities. And you can't believe me if I said some of our staffs are belong to another ministries, like accountants, internal auditors, storekeepers. All these belong to the Ministry of Finance. And our legal advisors belong to the Ministry of Justice. Our head of personnel belong to the Ministry of Labor. So these categories, I have no control on them. And when you, for example, when you train the account to familiarize themselves with the like profit and loss account, balance sheet for this kind of organizations, they rotate them. So they within the pool of the government, they rotate them from the between ministries and government organizations. So it's very difficult to, keep or maintain this kind of stuff. But this is our supply chain model. And BAM with us, I modified this from one of your slides, if you remember. And as I mentioned earlier, in the upper stream of supply chain, we have these challenges of scarcity of foreign currency, registration of pharmaceutical sanctions, because we, as I mentioned earlier, we cost recovery system. Sometimes we distribute free, we have two kind of health financing. We have cost recovery where patients pay for their medicines at the service delivery point, and we have free medicines. Free medicines is financed by the government. So the government should pay us on monthly basis. Sometimes the payment is delayed and we run in debt with the shortage of cash sometimes. So this is our main challenge. And this is a supply chain, this is our central warehouses, the blue color. And as we all know that if you have overstocks, then because we self-financing, we tied up the fund, and expiration, warehousing expenses increase. And why we do this? It is not because of we are not trained in the forecasting and quantification, but sometimes because of the sanctions, if you have an invoice and we find the international bank that will accept transfer of Sudan to this supplier, our colleagues buy big quantities because they thought that maybe next time we couldn't do transfer. So this is increase the quantities we have and the cost of it, and all the disadvantage of having big stocks. And the opposite is true when we run out of stocks. So these users lose their confidence in the health supply system and in the NMSF in particular, because all the Sudanese people know that we are responsible for the supplies of medicines to all health facilities across the country, and all the other disadvantages. Sorry for that. And the demand, as any other supply chain for health commodities, affected by these different factors like prescribing patterns, dispensing, standard treatment guidelines, and these issues. Continue the changing the paradigm. So what we do to work with all these challenges. First of all, when we embarked on this reform in 2011, we start thinking of having a rapid evaluation of organization to see the way forward. And we went through the process of hiring a consultants for this, and we came out with consultants from organization called Health Research for Action in Belgium, and then they came and do all the assessment of the supply chain functions and came out with a very important documents. And one of the top recommendations is to change the legal status of the National Medical Supplies Fund. And before at the time of evaluation, our organization named Central Medical Supplies Public Corporation. And the law governing that organization is called Public Corporation Act of 2003. And according to that act, the organization should pay some dividend to the Ministry of Finance, like, to support the public treasury. But in the reforms, they said that we have to change this legal status and we have to be a pure or mere cost recovery organization without paying any dividend to the ministry, because the patient pay, and we thought that this is one of the very bad discrimination in taxing the population, because when you tax the patients, this is a very weak people who couldn't even work. So we changed to non-profitable cost recovery self-financing organization, and we have our own act, which is national, and we've transformed from Central Medical Supplies Public Corporation to National Medical Supplies Fund, which is not profitable organization, and we just use our own revenues to finance ourselves. And also we have a radical change in the management structure. Before the reform, we have more than 12 general directorate, and now we are only 5, very compact. And at that time also the silos between different general directors within the organization. Now we work as a team, and I'll come to this later. According to this also, the new act, we established branches at the state level, because it is a matter of law. NMSF is responsible to get essential medicines to patient at the lower or the bottom of the supply chain and the last mile. So we established different branches in 16 states, and we have the new supply model, this one, this one. And as explained earlier, in the past, the health facilities come direct to the state and buy their medicines. So if you have no money, as a health facility, if you have no money, you can't get your medicines. So we changed all this old system to a new model when the NMSF send medicines to its branches, and then branches fulfill the requests coming from the health facilities, and the money start to come here only when the patients come and submit their prescription to health facilities, then they pay for their prescription and the money collected and come back to the NMSF. So as a health facility, you don't need to have any capital to buy medicines. And this is a very big shift because we split supply from the cash collection. And by doing this, we managed to make or sustain the flow of medicine to the health facilities and avoid the expiration due to big quantities in health facilities and expedite the fulfillment of emergency orders. And by the way, the availability of medicines increased from 46% for these models to more than 90%. Also, one of the very big changes that we have made is the integration of all health commodity supplies of national vertical programs in one system. Before the reform, we have 15 different national programs with their own supply chain, warehouses, everything. So we all accommodate them in the National Medical Supplies Fund. And this is a symbol of how we maximize the benefits of limited resources that we have. We also put a number of affordability measures because more than 80% of Sudanese people pay for their medicine out of their pocket. So before the reform, we put a markup of more than 50% on the cost of medicines, and now we only put 13%. It is just to finance ourselves. And we developed a national supply chain strategy for the first time with the experts and with support of the UNDP and Global Fund. This is, I will come to this later, but this is how we do the procurement. This is on the day of opening of the tender, because we use e-procurement. First time in March 2015, we rent a very big tent like this. This is representative of bidders sitting, and after at 12 o'clock, the screens display the quotations and automatically generate message to all mobiles of the bidders, more than 90 companies. And this is to establish branches in different states of Sudan. We give them the seed money in terms of medicines. We equip them with vehicles, for transportation of medicine from health facilities, from warehouses to health facilities, and also give them trucks and vehicles for supervision. The overall cost of this business is like almost 34 million US dollars. And this is a number of health facilities. You can see here. This is statistics from 2016. But now we reached more than 2,500 health facilities, our network. In the changing the paradigm also, we start computerization. This is maybe for some of you in South Africa is more advanced in this, but in Sudan, until 2010, we don't use computer. And you can't imagine. And our colleagues, they don't know even the email. So within the first months, we started to educate them and to give them an emails with our organization extension. And 2011, we used for the first time in my country electronic supplies. Our customers just place their orders online, and then we prepare the order and send it to them. And this is very, very breakthrough in my country. And as I mentioned earlier, the pool electronic procurement, we established this also in the 2015. And because it is we used to do tender every 2 years. And the number of companies participating in tenders is around 50 companies. But after we do this electronic procurement, we train them and we prepare them for the electronic procurement. We have more than 90 companies. And we're saving like 12 million US dollars or euro actually, because we pulled all procurement of the government together. So we made a very big saving. We have improved the warehousing, as mentioned by Dominique. We have a very big warehouse. This is our president, witnessed the opening of this warehouse and chairing a meeting in our training center for 5 hours, sitting with us for 5 hours. We also improved the transportation, and by donating this kind of vehicle, temperature control vehicle, to our branch, more than 30 different vehicles, and to avoid the scarcity of hard currency and to bypass the sanction, we submitted a proposal to the United Nations Development Program, and the concept of that proposal that we pay them, and this is, I think, something we can share with other countries suffering from scarcity of hard currency. We give them local currency to pay for their operation in Sudan, and then they use their hard currency to purchase medicine for NMSF. So instead of selling hard currency to bank and get local currency for their operation, they use this hard currency to purchase medicine for Sudan. Their contribution is like 1/5 of our needs. We also do some work on the waste elimination, and that we reduce the medicines waste due to expiration of medicine from 7% to only 1% per year. And we improve, I will show you that how we improve the delivery. In the past, our customer come and pick their consignments, but now we deliver it to them. We also establish hotlines to receive queries and also to avail medicine on prescription base, because during the past 3 years, the medicine are not available in the private sector. So the patients suffering from getting their prescriptions of rare medicines. So we have these hotlines and WhatsApp application to, sometimes they send their prescription or the box of the medicine and we brought it to them. This is our transportation system before the reform. This is how we used to get medicine from Port Sudan to our central warehouse in Khartoum, and now we use this and source out this service to a company. And in the past, the government at the state level transport medicines in these kind of vehicles, and now they use this very temperature control is data loggers. This is our training center actually, but before that we developed, as mentioned by Dominique, human resources strategy, and one of the consultants sitting with us here, my friend Bastian, is from Cape Town. He spent some time with us, and actually they came out with 4 deliverables and very, very useful documents, and now we follow them and we see their fruits actually. We also, as mentioned by Dominique, this is our training center with a library specialized in public health and supply chain for health commodities. We have a very comprehensive program for development of staff. As I mentioned, we started with computer literacy, and all our colleagues who have desk, we put for them a computer. And then we start, now we computerize everything. Even if they want, for example, sick leave or their holidays, they just submit it online. And because there is a big number of laborers and drivers, we have stations in corridors for these people who have no desk to put a computer on. And this is all the strategies we do and materials to develop them. This is our training budget, increases from 100 to more than 750, because we find it very useful to invest in the human resources, as I mentioned earlier, because you can't change them, you can't recruit what you want, so you have to invest and to train the people that you must work with them, you have no other choice. And then actually they are very responsive and they are now very committed and loyal. This is a number of training courses per year, and this is a number of trainees participate either in short courses in Sudan or from abroad. We have, as mentioned by Dominique, we have our own policies to retain the qualified staff because we have immigration to the Gulf states and how to maintain them after you train them in international institutions by increasing their incentives, and we have offered them transportation from their homes to work and back home. We also insure them in the private insurance company, health insurance company. And also to motivate them, we empower them, we give them delegation, and we establish a very efficient reward and disciplinary system, and all these others, like we sign a code of ethics, 440 employees sign a code of ethics, and we put it in their file. We strengthen their ownership feeling by training and by giving them examples, by bringing the Minister of Health to talk to them, and higher management. This is operation of change, how we manage to do all this change without any resistance actually. Because first we agreed, we are 10 who are responsible for the compromise the higher management of the National Medical Supplies Fund. We agreed to provide improvement in the supply, to focus on the improvement in the supply chain. In the past, my predecessor mainly focusing on manufacturing rather than the supply chain. So he lost the direction, because our responsibility is to make medicine, essential medicine, available to the patients at affordable and quality. So we undertook, as I mentioned, this reform we talk about. We keep enthusiasm alive by giving them examples, as I mentioned, by bringing some people to speak to them, by send them for training overseas, and provided them understood the strategic and capacity building program to empower staff in supply chain. We have a regular meeting with employees, 3 meetings actually per year. One in the beginning of the year to all employees, more than 400, we sit together and discuss our annual reports. And then after 6 months, we have also a big meeting to discuss the achievement in the first 6 months of the year, to modify our plan if there's some shortage. And then in November every year to prepare for the plan of the next year. We train them also in the leadership and change management, and this course is conducted by our colleague Bamela here, and we found them very useful for the senior staff and mid-level staff, and for managers of the branches. Also, our colleagues have access to their bosses. We have no barriers. They just come and talk and discuss to each other. And we saw so many social activities to break these barriers and to discuss all issues with them. I think this is our partners, National Health Insurance, UNDP I mentioned, Global Fund. We do for the Global Fund storage and distribution of the Global Fund commodities to fight malaria, TB, and AIDS. We also the same function to the UNFPA. PTD, as mentioned by Dominique, we have a very good strategic collaboration with them, and also this a UK organization, Transit, they come and evaluate our transportation system and put a very good recommendation. They help us a lot, actually. I think I'll give you the Dominique. Yeah. Thank you very much for listening.
Yeah, so I wish we could end with Dr. Gamal and not me, but because I think this presentation has shown you that he's a visionary, he has exceptional leadership in changing the health supply chain in Sudan. And so I think there's just two big lessons here. There's political commitment is necessary, and the number 2 here is really you need a strong and knowledgeable leader, and that's what we've seen today in Dr. Gamal's vision. I mean, he's committed to learning. He serves as a role model. He instills organizational values and attitudes in the staff. The employees trust him. I've visited twice, and it's incredible what you see there. The amount of women he has working with him is amazing. So, he has really empowered and equipped them. And so finally, so just some lessons regarding motivating your staff, having skilled staff. There's a need for teamwork, the effective reward and disciplinary system he spoke about. getting employees at every level on board, and then finally this focus on the supply chain, that improvement process. So, well, thank you very much. So.
I don't know if there's any questions for our panel. We still have about 3 minutes or so.
Oh, okay.
Well done, Dr. Gamal. I just have a simple question. What are the top 3 things that you had to do in retrospect to succeed as you've done so well?
3 things. I think one of the things is in the future, you talk about the future, you know? Yeah, we still have to improve the our logistic management information system, because we at the bottom of the supply chain, now we use the issuing data to determine on quantities and forecasting, but we need to improve this part of the supply chain information, flow information from the bottom of the supply chain. And also we now embarking on the digitalization of the supply chain at the health facility, because now we are up to the state level. So our future plan is to come down to the health facilities itself. Number 3, to find the solution for the scarcity of hard currency, because it's still suffering.
I would imagine it requires extreme patience to work in such a complicated environment.
Yes, you can't imagine.
Any other question? Okay, if there is nothing else, I think as our token of appreciation from SAPEX, both Dominique and Dr. Gamal.
Yeah. Thank you very much.
Please do not forget to do the speaker evaluations on your app. And I see Pamela wants to say something.
No, really, just to commend Dr. Gamal for the work that they are doing, because I've been there myself, and I've been to many, many developing countries, poked my nose into the systems there, and I tell you, without the leadership and the right leadership, even if you have a positive minister who wants to bring change, without the right leadership of the steering, you cannot get anywhere. And for me, Gamal is a true example of a leader who's really set his eyes on change with a vision and is driving something incredible there under difficult circumstances of years of sanction and all the changes that we talked about. There's so much that we can learn from there. I mean, South Africa is definitely in its own league, but other developing countries really have a lot to learn from how you can use the limited resources and achieve still so much, because the issue has always been, oh, we don't have money. We don't have money, and then we get into this dependency syndrome. But they didn't have to rely on anyone. They looked inward and said, what is our opportunity here? And they turned their threat into something that is getting them to develop something that they will sustain by themselves. Thank you.